I'm privileged and honored to be the moderator of this extremely exciting and upcoming session on robotic surgery in various fields. I'm Dr. Ruma Sinha. I'm a consultant gynecologist and laparoscopic robotic surgeon at Apollo Hospital, Hyderabad. For last 8 years, robotic surgery has been my passion. Since I was introduced to this form of surgery, initially I was wondering whether I really needed robotic surgery in my armamentarium, having been an accomplished laparoscopic surgeon. But believe me, over 8 years, I have realized that having been able to do everything laparoscopically, I have managed to find robotic surgery in my armamentarium to help myself do much better in complex situations. So, the bottom line of the most important thing that robotic surgery has made a difference in my uh, surgical career is reduction in open surgery. So today in this session, we have three stalwarts who will be speaking to us in their areas of expertise. Dr. Mani Menon, urologist, eminent urologist from Detroit, USA. Dr. Venki Munikrishnan, who is a colorectal surgeon from Apollo, Chennai. And Dr. Meenakshi Jain, who is also an eminent and a teacher and a proctor for robotic surgery from Florida, USA. I also welcome the chairpersons for this session, Dr. Arun Agarwal, Dr. Arul Raj, and Dr. Shailja Chaturvedi. Robotic surgery has been around in this world over for last 2 decades. It was spearheaded in USA by Professor Mani Menon in the field of urology. However, today it finds its place in almost all areas of surgery. Today, specialties like general surgery, benign gynecology, ENT, oncology have all embraced this technology to help them to do much better in complex situations and get better patient outcome. So what is robotic surgery? It's actually a logical step in the field of minimal access surgery. So the problems that we used to face with straight stick laparoscopic surgery has been taken care of or has been addressed by this system of computer-assisted surgery. In fact, I think robotic surgery is a probably misnomer. We need to call it a computer-assisted surgery that helps the surgeon with various facilities that it provides for us to do a better job. And I think we will gain this information by our three eminent speakers in the sessions to come. Please send your questions in the chat box, and we will be very happy to return an email answer to you within a week. So remember to put your name and email while you are sending your questions. So let's begin the session. May I invite Professor Arun Agarwal, the chairperson for the talk, to come and be with us. Professor Agarwal is an eminent ENT surgeon and ex-dean of Maulana Azad Medical College. He's an additional director general of Health Services, Government of India. He's a governing council member of Health Sector Skill Council. He's a medical advisor for innovation, education, and clinical excellence at Apollo Hospital. So Dr. Arun Agarwal, the stage is all yours. Please introduce Professor Mani Menon, and let's begin the first talk. Thank you.
Thank you, Dr. Ruma Sinha, for the lovely introduction you have given for me. And I will also like to thank GAPU for giving me this opportunity to chair a wonderful session on robotics. I would like to introduce my speaker, and my speaker is none other Dr. Mani Menon. Dr. Mani Menon, a graduate from JIPMER, Pondicherry, who is the Rajendra and Padma Vitikuti Chair in Urologic Oncology and Henry Ford Health System. Dr. Menon became chairman of the Department of Urology at Henry Ford Hospital in 1997, 23 years back, where he started incorporating computer-based integrated surgical system into clinical practice and established the first cancer-oriented robotic program in the world. The technique developed by Dr. Menon have revolutionized in the field of urological oncology and laid the framework for the extension of robotics to other surgical disciplines. Dr. Menon's work has been recognized through some of the highest honors in the field of urology, such as Gold Cystoscope Award, Who Hampton Young Award, and Keys Medal. Dr. Menon has published over 1,000 manuscripts. I've heard about 100, but for the first time, I'm hearing thousands manuscripts, book chapters, abstracts, primarily in the field of robotic surgery, kidney transplant, kidney transplantation, and urolithiasis. I would like to invite Dr. Menon for his talk.
Hello, I'm Mani Menon from Henry Ford Hospital in Detroit, and I'd like to thank my good friend Chairman Pratap Reddy for 40 plus years of friendship, Anupam Sibal, whom I've known for about 10 years, the moderator of the program, Dr. Sinha, and the chairperson of the program, Dr. Agarwal. My topic is what's new in robotics and urology, and I'm going to briefly restrict myself to what we have done and what's new in robotics and urology from our institution. And when we're talking about the robot, we're talking about two systems. The standard in the United States is the Da Vinci Xi system, and the new standard is going to be the single port system or the Da Vinci SP system. All the work that I've done is with the Da Vinci Xi system, since the SP system in our place has only been here for about a month. The outline of my presentation is it is difficult to innovate surgically, and the models for surgical innovation are different than the models for innovation of drug therapy or even radiodiagnosis. So the model for surgical innovation is the ideal model, and I was going to talk to you about our work with this, and I was going to introduce two areas where we have used the ideal model for innovation. One is robotic kidney transplantation, and the second is the precision prostatectomy for the treatment of prostate cancer. The ideal model asks us how we can innovate in an evidence-based manner with minimal risk to the patient. The model is based into 5 stages. Number 1 is idea. Number 2 is development. 2B is exploration, 3 is assessment, and 4 is long-term study. For robotic kidney transplantation, we've done all 4 steps of this. This is perhaps the first surgical procedure that has gone through the ideal phases. For precision prostatectomy, treatment of prostate cancer, we are at level 2B. We still have to do level 3 and level 4. Hopefully, someone in India will collaborate with us for those levels. To this concept, we brought our own innovation, which is the preclinical modeling, stage 0, and that has been incorporated in IDEAL in later versions of the study. And again, going through this, early clinical studies are stage 1 and 2, the randomized control trial is stage 3, and stage 4 is wide acceptance. This is a cartoon of robotic kidney transplantation with regional hypothermia. And we did this in collaboration with Rajesh Alawat at Medanta and with Pranjal Modi at the Kidney Institute in Ahmedabad. The work that I'm presenting has been continued with Rajesh Alawat.
In this video, we describe our novel technique of robotic kidney transplantation with regional hypothermia. The port placement is as shown and is similar to a standard robot-assisted radical prostatectomy port placement with an optional 4th arm on the patient's left side. Surgery starts with identification of the external iliac vessels. The vessels are then carefully skeletonized, exposing the external iliac artery first, followed by the external iliac vein. After harvesting the graft kidney laparoscopically, it is defatted on the table. Simultaneously, modified Toomey syringes are being prepared with ice slush. The graft kidney is wrapped in a gauze jacket filled with ice slush. An opening is fashioned to allow access to the hylar structures. With the robot still docked, the camera and gel seal cap are removed to allow for a resistance-free insertion of the graft kidney through the Alexis wound retractor into the pelvic cavity. The gel seal cap is then reattached and the camera redocked. Immediately following the introduction of the graft, about 120 cc's of ice slush is introduced around the vascular bed via modified Toomey syringes. This same step was performed just before the introduction of the graft to achieve uniform cooling. After stabilizing the graft kidney, with or without the assistance of the fourth robotic arm, the external iliac vein is clamped proximally and distally using robotic bulldog clamps. A venotomy is made using cold monopolar scissors. The graft renal vein is then anastomosed in an end-to-side continuous fashion to the external iliac vein using a Gore-Tex CV6 suture, beginning with the posterior wall. Black diamond microforceps are used in the non-dominant hand as they allow atraumatic and precise handling of the vessels. The anastomosis is flushed with heparinized saline and is then completed. The graft renal vein is occluded using a bulldog clamp. Both proximal and distal clamps are then removed from the external iliac vein. Next, in a similar fashion, the external iliac artery is clamped. For arteriotomy, a small incision is made in the arterial wall. A circular arteriotomy is made. With the help of a 3.6 mm aortic punch, the renal artery is anastomosed in an end-to-side continuous fashion to the external iliac artery. The anastomosis is flushed and the integrity of the anastomosis checked. The abdomen is closed in the conventional manner and on-table ultrasound was performed to check for renal graft perfusion. A 3-month follow-up, non-contrast CT scan showed no change in graft position or any evidence of perigraft collection in patients who underwent robotic kidney transplantation.
So here are the patient and graft survival. The blue represents robotic kidney transplants. The red line represents open kidney transplants, and you can see that there is no difference. These are the first 20 or 30 cases that we did, and it goes up to 48 months of follow-up. No difference at 36 months in graft survival. No difference in 36 months at overall patient survival. We found that robotic kidney transplant was associated with lower blood loss, a smaller incision, less pain and requirement of narcotics, and reduced wound complications and symptomatic lymphoseals, whereas the outcomes of graft function, rejection, and survival were the same. Rajesh Alawat has taken this across the world, and people he have trained, he's introduced it in over 20 centers, and as of 2019, over 2,000 patients have undergone robotic kidney transplants. And you can see it goes from the USA to Europe, to China, to India. The second procedure that is new and that we have been involved in innovating with the robot is a precision prostatectomy. The background on this is that a radical prostatectomy cures people of prostate cancer. And this looks at 5,258 patients whom we operated on over the first 14 years. So it'll be 2000 to 2014. And the blue line indicates that 99% of them don't die of prostate cancer. The downside with this is that many patients have erectile dysfunction because of nerve damage. This is a study from Memorial Sloan Kettering. It's not our study. And the blue line shows that 17% of men were potent at 1 year, and the red line shows that it's about 27% at 2 years, which means that 83% of men at 1 year and 73% of men at 2 years are not having functional erections. So a way that we thought that we could avoid this is by doing an exaggerated nerve sparing and doing a 95% prostatectomy. So in order to see who we could do this, we had to precisely map where the cancers were. And what we found is that most patients have a dominant lesion on one side, and then they may have non-dominant lesions on the other side or on the same side. There is a prostatic capsule, and we tried to preserve the prostatic capsule with this procedure. I'm sorry, let me go back and you'll have to edit this, Varsha, run the video here. Once again, I'm showing the dominant and the non-dominant lesions. I'm showing the various fascial coverages of the prostate, focusing on the prostatic capsule. And for a simple prostatectomy, which we do for BPH, not cancer, this is the plane of dissection. And that's the plane that we use for a simple prostatectomy over here. For a radical prostatectomy, this is the plane we use. But when we do that, we are removing a fair number of nerves. And for a precision prostatectomy, what we do is in one area where the cancer is not, we don't use the radical plane, but we use a slightly modified plane, which is 5 millimeters inside. So here will be the radical plane on the side of the dominant lesion, and here will be the precision plane. So this allows us to preserve all these nerves, which we have calculated is about 1,000 extra nerves that we are able to preserve with the precision plane. And let's see what this video is. So here we're showing a conceptualization of the dissection. You start this in front of the ejaculatory duct, and then you go around and release it. I'm going to fast forward a little bit and go to the results. So this is a diagram that tells us what we accomplished. These are patients, these are the control patients, and they had total removal of the prostate. And before surgery, this was their potency. And the bigger the circle, the more potent they are. After a nerve-sparing radical prostatectomy, this is their potency. And you could see that 33% of men were potent at 4 months after, if you remove the entire prostate, including the capsule on both sides. I'm going to skip over that. These are the results with precision prostatectomy, and you can immediately see that the red area is much bigger than if you took out the entire prostate. So the only difference between these patients and the first group of the control patients is that we are preserving the capsule on the side opposite to the dominant lesion. And you can see that with this result, with this approach, 83% of the patients were potent at 4 months. If you follow this up to 12 months, which is the standard for measuring erectile dysfunction, it's close to 100%. So we are leaving a little bit of the prostate, and so we worried about the PSA data, and you can see that at 12 months, the median PSA is undetectable. So whatever little prostate that we're leaving behind seems to be destroyed by the body. In summary, precision prostatectomy is a form of focal therapy that results in better preservation of erectile function than total radical prostatectomy. We are performing this as part of a clinical trial at Henry Ford Hospital, and we will shortly be opening it up to a randomized controlled trial. If there are any urologists in your audience who would like to learn more about this, we'd be happy to collaborate with you and get you involved in these studies, much like we did much like Rajesh Alawat did with the kidney transplant program. And the randomized trial will shortly be started here. Because of the title of this topic, I thought I should just mention certain new robots that are being used. The Senhance, Versius, which also Avicenna, Samsung, and Covidian robots, Johnson & Johnson robots. They are all under various stages of evaluation. None of them has actually had robust clinical trials, but I just throw that up in case the audience is interested, and so that you don't think that the field has stood still with just one robot made by one company. The robot made by the Da Vinci system is excellent, and the bar is high, but there are many, many people who are in this field, and shortly you will be able to have a plethora of options with different strengths and different weaknesses. Once again, thank you, Anupam, and thank you, Dr. Reddy, and enjoy the rest of this meeting. Bye.
Thank you, Professor Arun Agarwal, for conducting this session, and I profusely thank Professor Mani Menon for his brilliant talk on new innovations in urology. Robotic surgery, sir, has been your baby, I must say. In USA, you brought this in forth, and everybody was inspired by your use of robotic in the surgical field, and we all emulated you. So the talk about having precision prostatectomy as well as use of robots for doing renal transplant is an exemplary example of how innovations can work. Thank you so much, and we appreciate your talk. Thank you. So let's begin the second part of this robotic surgery symposium. And I now invite Dr. Arul Raj to take over as a chairperson and invite our next speaker, Dr. Venki Munikrishnan from Chennai. Dr. Arul Raj is the National President of Association of Physicians of India. He is the adjunct professor of MGR University, Chennai. He is also the founder and chairman of Commonwealth Medical Association Chambers in UK, as well as the founder and chairman of Medical Association of Indian Global Cardio Diabetes Academy. He is a past president of Commonwealth Association of Medical Association in UK, as well as the past president of IMA Delhi. So we are happy to have you here, Dr. Alraj, as the chairperson. May I now request you to invite and introduce Dr. Venki Munikrishnan for the next talk. Thank you.
Thank you so much, Dr. Sinha, for the nice words said about me. I am very much thankful to Gapio for giving me an opportunity to chair a session during their popular Global Indian Physicians Congress. Now it's my duty to introduce Dr. Venki Munikrishnan, who is a very eminent robotic surgeon, not only in Apollo Hospital, Chennai, but also in the UK. He had been a co-chair at Cleveland Clinic and University College of London, as an examiner of Royal College of Surgeons at Edinburgh. He is also a senior lecturer of surgery at University College of London. And Dr. Venki Munikrishnan is not only an expert in colorectal robotic surgery, and also put the name of India and Chennai in the global map. And we are lucky and we are so happy to introduce Dr. Venki Munikrishnan. And with these few words, I request Dr. Venki Munikrishnan to deliver his talk on robotics.
Hi, I'm Dr. Venkatesh Munikrishnan. I'm a consultant colorectal surgeon at Apollo Main Hospital, Chennai. I would like to thank Gapio for the opportunity to talk about robotic colorectal surgery, and Dr. Uma Sinha and Dr. Arul Raj for the opportunity as well. So, robotic colorectal surgery has evolved in the last few years. Particularly, the focus has been on rectal cancer surgery because most of the work has been around this field, although the indications are evolving. So let's focus on where we are in this field. So which technique to use for robotic colorectal surgery, particularly rectal cancer surgery, is been a topic of discussion. There is an open technique, there is a laparoscopic technique, there is a transanal technique, and a robotic technique as well. So, but most of the work has been around laparoscopic surgery, and laparoscopic rectal cancer surgery has been the standard for total mesorectal excision of the rectum for rectal cancer in particular. Now, but there are challenges with laparoscopy, particularly in obese patients, patients with a narrow male pelvis in particular, and if you have bulky tumors, post-chemoradiotherapy, particularly in the subcontinent, we have patients who are young with bulky tumors presenting at a late stage. So these are very challenging tumors to deal with, particularly with laparoscopic instrumentation, because you get straight sticks, and it can be very difficult working in the pelvis. And also, the conversion rates have been about 16% for laparoscopic TME rectal cancer. So, looking at the studies for laparoscopic surgery for rectal cancer, the evidence has been that there is no big difference between lap and open for rectal cancer in particular. But the more recent studies have said maybe newer technologies which are coming into play, like robotics, may change the outcomes. So let's look at the current use of robotics in colorectal surgery, mainly used for rectal cancer TME, also colectomies, for rectal prolapse surgery, transanal excision of rectal tumors. But most of the data which is available is for robotic rectal cancer surgery, and so we'll look at that. Some data for colectomies and some data for rectal prolapse with ventral mesh rectopexy and transanal rectal tumor resections. So looking at where we are with robotic colorectal surgery in India, we've seen a steady increase in indications, and also the numbers. The numbers are slowly but steadily increasing in India for robotic colorectal surgery. So what is the evidence in summary for robotics compared to lab is that with robotic colorectal surgery, there is definitely shorter length of stay, lower conversion rates, 4% convert compared to 16% for laparoscopic surgery, equivalent oncological outcomes, better sexual and functional outcomes in some studies, but increased operative time and increased cost. I think those two are the big challenges for robotics. But having said that, most of the data comes from case series, retrospective series, and only one randomized control trial, which happened some time ago. And so since then, newer technologies have arrived, newer models of the current robot have arrived. So I think if you do the same study now, I think you will probably get different results. And the newer XI model, for example, which is part of the Intuitive lineup, is well suited for multi-quadrant resections. It is a quicker setup. So, and also we've seen that with increased volumes and experience with robotics, the operative time and costs go down, and that's been shown in some studies as well. So looking at what we've done in the subcontinent, particularly in the Apollo Main Hospital in Chennai, where we are one of the busiest units in the country, and for robotic colorectal surgery, we've invested in team training. All our entire team, the surgeon, the bedside team, are all trained on the robot, so as a team, because that becomes very important, because each one understands their role. So we have developed a bedside team and a console team. So so surgeons working in tandem rather than the same surgeon scrubbing for both parts of the operation. So that sort of increases the efficiency of the procedure. We've invested in subspecialization, so we are organ specific now. So in our unit only does colorectal surgery, particularly our area of interest is rectal cancer surgery. We've seen that there is an increase in case volume. The laparoscopic experience is always a question people ask. Me particularly, if can you jump from open to robotics? I think yes, and people find it much easier. But laparoscopic experience definitely helps you, augments your skill sets with robotics. And also this leads to increased robotic volumes and experience, and then we've refined the technique, and what we're seeing is reduced OR times and costs, eventually leading to best patient outcomes. So let's deep dive into robotic rectal cancer surgery and see what are the little things which we did apart from team training. So as you see, there is a console surgeon sat comfortably, and I think that's very important because in laparoscopic surgery, the surgeon is usually standing. It's long operations, particularly for difficult rectal cancer, can take about 5-6 hours on an average, and it is a strain if you're doing that in and out, day in day out. And to have a comfortable, well-seated position with your elbows rested, I think ergonomically is a much better way to operate. And another thing which I would like to highlight is the availability of the Firefly technology. Here, particularly in we're dealing with rectal cancer, particularly the elderly population. They may have other comorbidities like coronary disease, where you're not sure the blood flow, how well the vascularity is. Here you can inject the dye, indocyanine green, and you can see the fluorescence, which which with the flick of a switch on the robot, you can swap to the screen and make sure you identify a well vascularized bit of the bowel, confirm it, because I'm sure you need to just cut it bleeds. We've seen that before, but confirming this with that the vascularity with the fluorescence really sort of guarantees us that okay, it's a safe area to anastomose, and and when you make the joint, so you could use it even if you're doing a coloanal anastomosis, when you slip the rectum out through the anus after the dissection. You can still give the ICG and make sure and then cut at the appropriate place to perform the anastomosis. And I think this Firefly technology is amazing and is very useful part of the robotic instrumentation. So looking at data, I think that's what it boils down to. So what we've seen is from this is a small bit of a set of patients. We've seen that the completeness of the rectal cancer specimen is excellent. The nodal harvest is well within what's recommended. Our leak rates are way below what's reported in the literature. Resection margins are, again, about 5.7%, which is good, and length of stays, between 5 to 6 days, and that's acceptable. Looking at also first 75 cases and second 75 cases, as experience has been building, we've seen that the console time goes down. That's the operative time. So and also the cost goes down. So as we discussed earlier, the two big challenges with robotics is the OR time and the cost. And I think with developing dedicated teams for bedside and the console, team training, and subspecialization, high volumes, and I think over a period of time, your console time will come down, and also the cost goes down. So this is a summary of our robotic colectomy work. This is about 92 patients in the subset. We've compared that with the American College of Surgeons NESQIP data, which was published in 2017, and we're looking at our complication rates. So the first one is open, the second gray, darker gray is lap, and the darkest gray is robotic NESQIP data, and the golden bar is our data from Apollo Chennai, and you can see that the complication rates are 8.7. Our wound infection rates are less than 1%. Anastomotic rate is 1%. Our length of stay is about 6 days. That's because in our practice, most of our patients come from out of town, so they tend to stay and make sure that although they're ready for discharge probably on the 4th day, but they stay because otherwise they have to go stay outside and travel. They would rather stay in the hospital and ensure that they're absolutely fine before they leave. So normally patients have a bowel movement before they leave, primarily because they come from out of town, and the way our healthcare is set up, that probably works better for us. But if you look at our readmission rates, it's about 1%, and I think that's what is a difference compared to the NESQIP data that shows that our patients, our readmission rates for complications are less, and I think that's good data. So to confirm, why they stay a bit longer. So looking at our rectal cancer data, this is a subset of 235 patients. Again, we're comparing this with the American College of NSQIP data, and so open lab robotic from the ACS data, and comparing that with our data from Apollo Chennai. Margin postulates are very similar. Our leak rates are less than 1%. Our wound infection rates are again 1.4%. Length of stay, as we discussed for the colon subset, again around 6.1, and our readmission rates are about 1.9%. So basically reflecting that patients stay slightly a bit longer because they want to ensure that everything is sorted before they leave, and so that's our data. And so in summary, robotic colorectal surgery is evolving, and it's here to stay, and it's safe. Particularly in rectal cancer surgery, standardization is key. Oncologically equivalent to lap or open for resectable rectal cancer. That's been our experience, and I think most of published data would reflect that. Improved short-term outcomes, and we've also seen that high volume plus efficiency will give you a cost equivalent to laparoscopic rectal resections. Thank you so much for the opportunity.
Thank you, Dr. Venki Munikrishnan, for an excellent talk. And as we are talking about the new technologies in our surgery, it was excellent of you to use and discuss how Firefly is helping you to do rectal and colorectal cancer surgeries by using robot. I also thank Dr. Arul Raj for being the chairperson of this session. It was a privilege to have both of you for the second half of this meeting. Thank you very much. This is the third talk in our session, and I now invite Dr. Shailja Chaturvedi to be the chairperson for the talk which has been invited to be given by Dr. Meenakshi Jain. Dr. Shailja Chaturvedi is a consultant psychiatrist in Australia. She is the past president of Australian Indian Medical Graduate Association. She is at present the committee member of GAPIO and a member of the core group of Women's Forum at GAPIO. Dr. Shailja Chaturvedi, we welcome you to this session, and we now request you to invite Dr. Meenakshi Jain for her talk.
Thank you, Dr. Roma Sinha, for introducing me as the chairperson of this session, which is on robotics. I would like to thank GAPIO for this extraordinary virtual conference on the digital stage. And the timely topic is the challenges faced by women and robotic surgery. The opportunity given to me to chair this interesting session in advanced technology, I would like to thank for that to GAPIO and our chairperson. I would like now to introduce Dr. Meenakshi Jain, whose work in robotic surgery is highly impressive and commendable. So Dr. Meenakshi Jain is a board-certified practicing gynecological surgeon in St. Petersburg, Florida. Dr. Meenakshi specializes in minimally invasive robotic surgery and chronic pain, which is often due to endometriosis and interstitial cystitis. And also she specializes in sacro-neuromodulation for urinary and fecal incontinence. Dr. Meenakshi is a mentor and proctor at the Epicenter for Robotic Surgery and also at the Surgical Center of Excellence at St. Petersburg General Hospital in Florida. Dr. Meenakshi has lectured in USA and have been proctor and teacher in many of the robotic programs in Delhi, Hyderabad, Calcutta, Apollo hospitals. So over to you, Dr. Jain. Thank you very much for presenting such an interesting topic. I'll be looking forward to listening. Thank you very much. Dr. Jain, yes.
Hello, everyone. Thank you for inviting me to give this lecture, and I want to especially thank Dr. Ruma Sinha and Dr. Shailja Chaturvedi, and my lecture is on robotic and endometriosis. I am Meenakshi Jain, and I trained in Maulana Azad Medical School, and then I came to Rochester, New York. I trained there. I was a professor at assistant professor at Press St. Luke's, and now I'm solo practice. I specialize in endometriosis, chronic pelvic pain, minimally invasive surgery, robotics, interstitial cystitis, and sacromodulation, exonics, and InterStim implants. I work at St. Petersburg General Hospital. We are the only epicenter at St. Pete in Florida, and we are the center of excellence in Florida. There are 3 other ones. We have 3 XI robots and 1 SI. And we do a fair amount of robotic surgery. I also have gone to India to teach robotics. That's where I met Ruma and excellent other physicians. And I went and trained in New Delhi Apollo Hospital, Hyderabad, and in Calcutta. So we're going to talk about minimally invasive surgery. Everybody knows about laparoscopy and vaginal, which is the least invasive, but laparoscopic surgery has been very common. And I think that we already know that it has reduced blood loss, fewer complications, shorter hospital stay, faster recovery, and less scarring. I used to be a very laparoscopic surgeon until about 10 years ago. I was going ahead and doing most of my cases laparoscopically. I was a very resistant robotic surgeon. I really didn't want to convert to robotic surgery because I felt that I could do everything with laparoscope. But very reluctantly, I started doing robotics. But now in the last 8 years, I have not done anything laparoscopic. I do everything robotic. The drawbacks, as you can see, surgeon in laparoscopic surgery, 2D image, rigid instruments. Instruments are controlled at a distance. Reduced dexterity, surgeon fatigue. I think we all know about difficult surgeries which are done where we're taking hours and hours on trying to do the surgery. Our assistant is very important. So the robotic surgery, of course, has, as we can see, there is a console, there is a patient cart, and then there is a vision cart. And the surgeon is in the at the console, managing and looking inside with a 3D and HD image. You have a console, it's a vision system. These are joysticks. In the vision system, I'm sure everybody's already said, and I'm not going to take too long, but there is a 10 to 15 magnification. It is a 3D HD image. You almost feel like you're sitting inside the belly. The instruments are like really small instruments, as you can see, the size. Wrist and finger movements, it's a 360 degrees movement, which is definitely beneficial compared to laparoscopic instruments. I always compare this to having dal chawal with chopsticks versus with fingers. The patients who really we were benefiting initially when I started, I was only doing robotic surgery for obese patients, somebody who's had multiple surgery, complex pathology, and by somebody who's had laparoscopy before and couldn't do it. And of course, large lesions. And I know Indian surgeons are fantastic in laparoscopic surgery. And I thought I was very good. And I thought I was because I only had a 10% incidence of laparotomy, which I thought was really good. That's why I didn't want to do anything robotics. But my first 10 cases I did were really these ones. And I really only did those cases which I thought I could not do laparoscopic. And I tried to do it robotically. And 7 out of 10, I could do robotic. And that's when my respect for robotics went. And now I feel all the benefits of laparoscopy and robotics, and none of the negatives are there. There are some misconceptions about robotic surgery. I published a technique called Jane technique, and which is what I use for my robotic surgeries. They did a study called Premier study, and they compared by my Jane technique. So you can see that one of the biggest thing is there is a high risk of conversion, complications are more, OR time is is much longer with robotics. These are misconceptions. As you can see, they compared it to my Premier study open cases and laparoscopic cases and compared it to my Jane technique. The conversion was very little. In the last about 3,000 robotic cases I've done, I've only had to open probably 6 open cases. Complications are much less. OR room time, which is another misconception that it takes a long time to do robotics, is not correct. I'm not going to go through it, but Da Vinci did some analysis and found that we were saving money when we were doing robotic. The hospitals are buying robots a lot, so that must be a reason. There must be something good. Jane technique, as you can see, I've been very blessed. I've never had any puncture accidents or any other complications. So now we are going to quickly talk about endometriosis. Endometriosis is diagnosed very poorly. I think there are tons of patients walking around with pelvic pain with very typical symptoms of endometriosis. And I really think that we should go back to what we were taught in med school, that history, and listen to the patient, what they're saying. Usually the symptoms in the patients with endometriosis are very similar. The younger patients, when they start, they have severe dysmenorrhea, they have severe lower abdominal discomfort. So patients who are young, a lot of 16, 17, 18-year-old come to my office and they have severe pain. Now, I'm not talking about somebody with mild dysmenorrhea. I'm talking about severe dysmenorrhea where they are doubled over in pain. They have been given birth control pills. They have been taking any antiprostaglandin and have no relief. A lot of these patients will have lower abdominal discomfort, mid-ovulatory pain, low backache, if they're sexually active, deep dyspareunia. And the symptoms progressively get worse in their 20s and 30s where they start getting endometriomas. A lot of these patients are given birth control pills, which makes their symptoms a little bit better. And if they get better enough, it's fine. But if they're very severe, they really should not be ignored. They should be, you should do a laparoscopy or robotic, which is what my preference is. The patients who are like in their perimenopausal age, once they are done with childbearing, a lot of them will have menorrhagia and symptoms of adenomyosis, which we all know. They will have heavy bleeding, cramps. A lot of these patients will also have backache, tenesmus, and depends if they have any other non-gynecologically conditions or if they have extra pelvic endometriosis. So a lot of these patients, going back to menorrhagia, they get an endometrial ablation. But if they have severe dysmenorrhea, I always recommend doing a laparoscopy with endometrial ablation. If they have very severe endometriosis, robotically you can do a TLH. I absolutely want to talk about postmenopausal women. I think it's a misconception thinking that their pain is never related to endometriosis. I think there are studies which have shown that there is a higher connection between endometriosis and ovarian malignancy. Whenever I have a patient who's referred to me, by the time they come to me, they've already had CT scans, ultrasound, pelvic pain, ultrasound, and have had a colonoscopy, and no pathology is found. And these women are then told that it's in their head, and they're crazy, and they have been sent for pain management. We should always look for non-gynecological conditions. These women who are back to what I was saying, we must scope them. A lot of times they've had hysterectomy and they may have endometriosis of the cervix if they had a supracervical. Sometimes they have residual ovarian syndrome with severe adhesions. Negative test does not mean negative pathology. Laparoscopy, the Da Vinci endometriosis resection is reproducible approach of treating complex, diffuse, deep endometriosis. Visualizing, you have to look for endometriosis, not just typical. You're looking for sclerotic lesions. You're looking scarring of peritoneum, stellate lesions, early endometriosis, flame lesions. A lot of those findings, and we have done studies where found that you can see a lot better with a robot exactly where you are accessing it. If it's on the ureter, on the lateral pelvic wall, you are going to be very carefully, and you can examine and you can excise easily. We all have done laparoscopies, at least I have, where there's endometriotic implant sitting on an iliac or sitting on the back of liver on the diaphragm, or it's sitting on the bowel. And sometimes it's like, oh my God, maybe I'll just cauterize. I think excision is definitely important, and I think we should do that. Benefit of robotic laparoscopy over traditional: exposure is better. Complex cases can be done. Endometrioma resection is the best thing. You can do very well and a lot easier with robots. Dissection is more detailed. Surgeon and assistant fatigue is negligent. Tenderness and everything. You guys can look at my slides. A lot of these patients have adhesions and are bloated and gassy. I always do enterolysis on the side, near the broad ligament, left lateral pelvic wall. I think it's a lot easier with the robot. And of course, endosalpingiosis and management with the robot. Exposure, excision is absolutely easier. When I gave a lecture one time in India and I made somebody upset, I didn't mean to, and they were like, you're teaching robotics to make surgeons exact words that you're dumbing down the surgeon. I don't know. And I really don't think so. I think the benefit of robotic is that they feel safer. And the reason when you feel safer, you can be doing a lot more aggressive cases. A lot of time when we were doing laparoscopies, the laparotomies were being done, there was still an incidence of 60% open cases when everybody was doing a lot of laparoscopies. I think since the robotics started, our incidence of opening a patient, especially for hysterectomy and all, has become much less, and therefore it is, I want to say it's a win-win for all. It's great for the patient, it's great for the surgeon. Robotic surgery is easier to learn, I think, with laparoscopy. I do believe that a person should be a good laparoscopic surgeon before they learn robotics. 3D magnification instruments make it better. Conversion rate is markedly reduced, and this is very important. We must realize that the conversion rate is the key, because then the patients can return back to their work and their postoperative complications, infection, ileus, everything related with hospitalization gets less. Postoperative recovery, physician fatigue, and I think robotic is awesome and it's fun. I'm just going to show you guys, these are patients. I just want to, if anything I can leave behind a message, is that you cannot say that the test is negative and then, and then feel that there is nothing wrong. These women are suffering in pain. We put a Band-Aid on them. This is a girl who was 30 years old, who came in with severe pelvic pain, typical symptoms of endometriosis since the age of 16, dysmenorrhea, dyspareunia, backache, pelvic pain affecting her marriage, bloatedness, gassiness. You can see this loop of bowel adherent. And she had a absolutely negative ultrasound. And I think that when you do these cases, you can manage these cases. This is just a robotic instrument being put in. I always, and you can see that she has extensive endometriosis. We had to excise all the area. She had endosalpingiosis. She had adenomyosis. So as you can see, a negative test does not mean there is no pathology. I urge everybody to be aggressive about scoping. Studies have shown that when we are looking for endometriosis, this is another patient who came in. So as I was saying, the patient with endometriosis, this patient had a negative ultrasound. Only thing was she had umbilical pain during her period. And as you can see it again, that she had this loop of small bowel, and I could do it robotically. Her symptoms went away. We excised the endometriosis. There are a couple of things. These are last two slides. I always do a laparoscopic uterosacral nerve ablation in all my patients. I have to do a shout out for it. If you look at any literature, they're like, well, we did 150 studies and Luna doesn't work. I can tell you that I have done at least 10,000 and it works. And patients who come in, I have never found a patient who had typical symptoms where did not have a pathology. I always do a Luna. You basically antivert the uterus, you cauterize the uterosacral ligament near the origin, you go ahead and excise and you transect the uterosacral ligament. And I think it works beautifully. And I think that this is something which we should do. And the other thing which I do in a lot of patients who, younger patients, I always do a uterine suspension. It helps them with their backache. It helps them with their deep dyspareunia and bloatedness. This is my experience. So with doing the Luna, I do a uterine suspension. Of course, postoperatively, they are put on medications, norethindrone or whichever combined birth control pill. I almost have very rarely have used GnRH agonists or antagonists, and I have an excellent pain relief in my patients. So I have a lot of videos on this site. It's a telemedicine site called kgi.com. So if you guys want to look at some more of my videos where I have endometriosis patients with negative pathology, these are unedited videos. You can go on Jane Gynecology. This is my team. Thank you very much. I hope I didn't take too long. It was an honor to be giving this lecture. Thank you.
I wholeheartedly thank Dr. Shailja Chaturvedi and Dr. Meenakshi Jain for this wonderful session on robotic surgery in endometriosis. I say this wonderful because this particular part is very close to my heart. Endometriosis is a difficult problem that women face, and I thoroughly admire how Dr. Meenakshi Jain treats and also teaches us to do this work. In fact, I'll share a secret. Dr. Meenakshi Jain has been my mentor when I started doing my robotic surgery, and I always tell her that her enthusiasm was so infectious that it actually helped me embrace robotic surgery the way she has. So thank you, Dr. Jain, for sparing your time and being with us in this session today. I thank you all very much for this session. Thanks. Now we come to the end of this session on robotic surgery. I thank Professor Mani Menon, Dr. Venki Munikrishnan, and Dr. Meenakshi Jain for sparing their time to enlighten me and the audience on how robotic surgery is changing the scenario of surgical field. I also thank our chairpersons, Professor Arun Agarwal, Dr. Arul Raj, and Dr. Shailja Chakravarti for joining us today and to hear these eminent speakers on areas of robotic surgery. Well, coming to the end of it, we need to go back home with some take-home messages. The first thing I want to talk here is that although robotic surgery is the name that makes us feel that there's a robot that does the surgery, but it's not so. Actually, the correct name should have been computer-assisted surgery. When the computer or digital things are helping us in every phase of life, why surgical field should be left behind? And that's the idea, that these innovations are trying to help surgeons perform better to give better patient outcomes. Now, this is a logical step in minimal access surgery. In fact, what we were unable to do or achieve by straight-stick laparoscopy, we are today able to do and achieve in minimal access surgery by the help of this robotic platform. I believe that giving patients outcome in better fashion and getting better patient survival rates is pertinent to a surgical procedure. So if the robotic platform is helping us give that, why not take the advantage and give this benefit to patients? And being gynecologist, today I will say that women deserve this technology much more than anybody else. They are the nodus, they are the pivot of their family, their society, the nation at large. They need to recover and they need to get the benefit of technology. And especially women who suffer from benign diseases like Dr. Meenakshi described, endometriosis or fibroids or any other situations. They don't deserve to have an open surgery. So today, the only take-home message that I would like our audience to take back is using this technology, using the robotic platform, although Da Vinci is the one that is synonymous to robotic platform today, many more are in the pipeline, as Dr. Menon also mentioned in his talk, and many more will be seen in the next 3-4 years in our surgical theaters. So let us use this technology to achieve, if not many, one purpose. And that purpose remains reduce the number of open surgeries, because there is no denying the fact that minimal access surgery has several advantages. We all accept that. So with this, I'd like to thank all of you for joining us today. And it has been wonderful for me to moderate this session. Thank you all and see you soon.